In this video, we are going to discuss about meningitis. Before going to learn disease condition, let us know what is meninges. The meninges are three layers of different types of connective tissue that cover and protect the brain and spinal cord. The outermost layer is dura mater, is made up of fibrous, tough, white connective tissue. It is a strong outer sac that encloses the brain, spinal cord, and the cerebrospinal fluid. It has many blood vessels and nerves and attaches to the inside of the cranial cavity. It also extends inward between the brain lobes to form protective partitions. It continues into the vertebral canal to surround the spinal cord, ending in a sac at its end. Next is arachnoid mater. It is a delicate cobweb-like layer lying beneath the dura mater that contains most of the blood vessels. The subarachnoid space separates the arachnoid and the pia mater. It contains delicate connective tissue through which cerebrospinal fluid circulates around the brain and spinal cord. The innermost layer is pia mater that follows the contours of the brain and spinal cord and adheres tightly to the highly folded surfaces. The meninges continue down within the spinal cavity for some distance below the spinal cord. The thin pia mater has many blood vessels and nerves that nourish the brain and the spinal cord. The pia mater is closely aligned with the surfaces of these organs. It is comprised of many tiny blood vessels and delicate connective tissue. Meningitis is an inflammation of the lining around the brain and the spinal cord caused by bacteria or viruses. In meningitis, infection causes inflammation of the brain and spinal cord meninges that can involve all three meningeal membranes such as dura mater, arachnoid mater, and pia mater. The subarachnoid space between these two meninges contains ESF that may reflect the signs and symptoms of meningitis. Meningitis is classified as septic or aseptic. The aseptic form may be viral or secondary to lymphoma, leukemia, or human immunodeficiency viruses, that is HIV. The septic form is caused by bacteria such as Streptococcus pneumonia or Neisseria meningitidis. Now let us see the causes of meningitis. Bacteremia, especially due to pneumonia, osteomyelitis, or endocarditis. Other infections such as sinusitis, otitis media, encephalitis, or myelitis. Brain abscesses, usually caused by Neisseria meningitidis, Haemophilus influenza, Streptococcus pneumonia, or Escherichia coli. Head injuries such as skull fracture, penetrating head wound, or neurosurgery. Bacterial or meningococcal meningitis also occurs in patients with acute immunodeficiency syndrome, that is AIDS, and as a complication of Lyme disease. Bacterial meningitis is the most significant form. The common bacterial pathogens are Neisseria meningitidis, meningococcal meningitis, and Streptococcus pneumonia, accounting for 80% of cases of meningitis in adults. Haemophilus influenza was once a common cause of meningitis in children, but because of vaccination, infection with this organism is now rare in developed countries. These are the causes of septic meningitis. Viruses or other organisms can cause aseptic meningitis. Aseptic meningitis is a benign syndrome is characterized by headache, fever, vomiting, and meningeal symptoms. It results from infection by enteroviruses is the most common. Arboviruses, herpes simplex virus, mumps virus, or lymphocytic choriomeningitis virus. These viruses are the most common viruses can cause aseptic meningitis. Now let us see the pathophysiology. Once the causative organism enters the bloodstream, it crosses the blood-brain barrier and proliferates in the cerebrospinal fluid. The host immune response stimulates the release of cell wall fragments and lipopolysaccharides, facilitating inflammation of the subarachnoid and pia mater. Because the cranial wall contains little room for expansion, the inflammation may cause increased intracranial pressure. CSF circulates through the subarachnoid space where inflammatory cellular materials from the affected meningeal tissue enter and accumulate. Next is clinical manifestations. Headache and fever are frequently the initial symptoms. Fever tends to remain high throughout the course of the illness. The headache is usually either steady or throbbing and very severe as a result of meningeal irritation. The patient may have vomiting, the patient may be malaise or weak, exaggerated and symmetrical deep tendon reflexes or opisthotonus. Opisthotonus is a reflex muscle movement of the neck and back when the brain is disrupted. Meningeal irritation results in a number of other well-recognized signs common to all types of meningitis. Signs of meningeal irritation such as knuckle rigidity, positive Brudzinski's and Kernick sign. Knuckle rigidity, that is a stiff neck, is an early sign of meningitis. Brudzinski's sign: place the patient in a dorsal recumbent position and then put your hands behind his neck and bend it forward. Pain or resistance may indicate neck injury or arthritis. However, if the patient also flexes the hips and knees, chances are that he has meningeal irritation and inflammation, a sign of meningitis. Positive Brudzinski's sign: flexing patient's neck produces flexion of the knees and hips. Passive flexion of lower extremity of one side produces similar movement for opposite extremity. Kernick sign: place the patient in a supine position, flex his leg at the hip and knee, and then straighten the knee. Pain or resistance suggests meningitis. Patient cannot completely extend leg. A positive response to these tests helps establish a diagnosis of meningitis. Photophobia, that is extreme sensitivity to light, is common. Patient may have rash caused by Neisseria meningitis. Ranges from petechial rash with purpuric lesions to large areas of ecchymosis. Disorientation and memory impairment. Behavioral manifestations are also common. As the illness progresses, lethargy, unresponsiveness, delirium, deep stupor, and coma may develop. Seizures can occur and are the result of areas of irritability in the brain. ICP increases secondary to diffuse brain swelling or hydrocephalus. Initial signs of increased ICP include decreased level of consciousness and focal motor deficits. An acute fulminant infection occurs in about 10% of patients with meningococcal meningitis, producing signs of overwhelming septicemia. An abrupt onset of high fever, extensive purpuric lesions over the face and extremities, shock, and signs of disseminated intravascular coagulation. Death may occur within a few hours after onset of infection. Aseptic meningitis begins suddenly with a fever up to 104 degrees Fahrenheit or 40 degrees Celsius. Alterations in level of consciousness, that is drowsiness, confusion, stupor, and neck or spine stiffness, slight at first when bending forward. Other signs and symptoms include headache, nausea, vomiting, abdominal pain, poorly defined chest pain, and sore throat are seen in aseptic meningitis patients. Next is assessment and diagnostic findings. CT scan or MRI scan to detect a shift in brain contents which may lead to herniation prior to a lumbar puncture. Typically, CSF testing and positive Brudzinski's and Kernick sign establish the diagnosis. We have to look for elevated CSF pressure, high CSF protein levels, and possibly low glucose levels. CSF culture and sensitivity tests usually identify the infecting organism unless it is a virus. The ESPERT EV test identifies the enterovirus in CSF. Next, we will see medical management. Treatment includes antibiotic therapy if the cause is bacterial and vigorous supportive care. Usually, the patient receives IV antibiotics for 2 or more weeks, followed by oral antibiotics. Vancomycin hydrochloride in combination with one of the cephalosporins, for example, ceftriaxone sodium, cefotaxime sodium, is administered by intravenous injection. Dexamethasone, that is Decatron, has been shown to be beneficial as adjunct therapy in the treatment of acute bacterial meningitis and in pneumococcal meningitis. Dehydration and shock are treated with fluid oleum expandase. Seizures, which may occur early in the course of the disease, are controlled with phenytoin or dilantin. Increased ICP is treated as necessary. Other prescribed drugs may include digoxin or lanoxin to control arrhythmias, mannitol or osmitrol to decrease cerebral edema, an anticonvulsant or sedative to reduce restlessness to be given, acetaminophen, that is Tylenol, to reduce headache and fever. Supportive measures include bed rest and measures to prevent dehydration. If nasal cultures are positive, isolation is necessary. Any coexisting conditions such as endocarditis and pneumonia are treated as well. Now let us see how to prevent the disease. Meningococcal conjugated vaccine be given to adolescents entering high school and to college freshmen living in dormitories. Vaccination should also be considered as an adjunct to antibiotic chemoprophylaxis for anyone living with a person who develops meningococcal infection. Vaccination against Haemophilus influenza and Streptococcus pneumonia should be encouraged for children and at-risk adults. People in close contact with patients with meningococcal meningitis should be treated with antimicrobial chemoprophylaxis using rifampin, ciprofloxacin, or ceftriaxone sodium. Therapy should be started within 24 hours after exposure because the delay in the initiation of therapy limits the effectiveness of the prophylaxis. Next, we will see about nursing management. Assess the patient's neurologic function often and watch for deterioration. Administer antimicrobial agents on time to maintain optimal blood levels. It is important to reduce fever. Monitor temperature frequently or continuously and administer antibiotics as ordered. Institute other cooling measures such as a hypothermia blanket as indicated. Be especially alert for a temperature increase up to 102 degrees Fahrenheit or 38.9 degrees Celsius, deteriorating level of consciousness, onset of seizures and altered respirations, all of which may signal an impending crisis. Reduce high fever to decrease load on heart and brain from oxygen demands. Maintaining fluid balance. Monitor the patient's fluid balance. Make sure he consumes enough fluids to prevent dehydration. Measure his central venous pressure and record intake and output accurately. Rapid IV fluid replacement may be prescribed, but prevent IV fluid overload because of risk of cerebral edema. Monitor daily body weight, serum electrolytes and urine volume, specific gravity and osmolality, especially if syndrome of inappropriate antidiuretic hormone is suspected. Enhancing cerebral perfusion. Determine oxygenation from arterial blood gas values and pulse oximetry. Insert cuffed endotracheal tube or tracheostomy and position patient on mechanical ventilation as prescribed. Assess blood pressure, usually monitored using an arterial line. For incipient shock which precedes cardiac or respiratory failure. Protect the patient from injury secondary to seizure activity or altered level of consciousness. Observe for signs and symptoms of increased ICP such as decreased level of consciousness, dilated pupils, widening pulse pressure. Maintain a quiet, calm environment to prevent agitation, which may cause an increased ICP. Prepare the patient for a lumbar puncture for CSF evaluation and repeat spinal tap if indicated. Evaluate the patient for ICP prior to lumbar puncture. Notify the healthcare provider of signs of deterioration, that is, increasing temperature, decreasing level of consciousness, seizure activity, or altered respirations. We have to reduce the pain of the patient, administer analgesics as ordered, monitor for response and adverse reactions. Avoid opioids which may mask a decrease in level of consciousness. Assist with position of comfort for neck stiffness and turn the patient slowly and carefully with head and neck in alignment. Elevate the head of the bed to decrease ICP and reduce pain. Relieve headache with a non-opioid analgesics such as acetaminophen as ordered. Opioids interfere with accurate neurologic assessment. We must promote mobility of the patient. Frequently turn and reposition the patient to prevent skin breakdown. Progress from passive to active exercises based on the patient's neurologic status. Suggest early physical and occupational therapy referrals to promote a return to optimal level of functioning. Position the patient carefully to prevent joint stiffness and neck pain. Help with range of motion exercises. Prevent complications associated with immobility such as pressure ulcers and pneumonia. Maintain a quiet, comfortable environment. If necessary, darkening the room can help reduce photophobia. Use strict aseptic techniques when treating the patient with a head wound or skull fracture. Maintain adequate nutrition and elimination. Provide reassurance and support to the patient. The patient may be frightened by his illness and the need for frequent lumbar punches. If he is disoriented or confused, calm and reorient him as often as needed. Reassure the family that the delirium and the changes in behavior caused by meningitis usually disappear during recovery. However, if a severe neurologic deficit appears permanent, refer the patient to a rehabilitation program as soon as the acute phase of the illness has passed. Institute infection control precautions until 24 hours after initiation of antibiotic therapy. Oral antinasal discharge is considered infectious. Inform family about patient's condition and permit family to see patient at appropriate intervals. Evaluate the patient's progress. If treatment is succeeding, the patient will be pain-free and his level of consciousness will be normal. He will maintain adequate hydration and nutrition, and his blood pressure, heart rate, and respiratory rate will remain within normal limits.